to our presentation. I'm Carmen Ortiz, and I am the Executive Director of Círculo de Vida, Cancer Support and Resource Center here in San Francisco. And I'm going to talk a little bit about Círculo de Vida, and then about how my partnership with Ana began. I'm going to talk a little bit about our history, our collaborations, to include 3 studies. And then Anna's going to talk about collaborative data collection, analysis, and dissemination. And then we'll leave some time at the end for discussion and questions. So can everybody hear me? Okay? Yes? All right. So Círculo de Vida is a cancer support and resource center here in San Francisco. It's in the Mission District, which is primarily Latino population. And we began with one support group, one Spanish language support group, through another English language organization that was here in San Francisco, and they started this Spanish language support group for Latinas in 1992. And I came on in 1995 and took over the support group. And at that time, there were only 3 women in the group, and it was already 3 years old. So I did a bunch of things, changed a bunch of things, and tripled that number in about 4 to 6 months. At one point, I had 16 women in the support group, and I had to start a second support group for Latinas. That organization eventually closed its doors. I took the groups with me, and eventually with a group of community advocates and providers, founded Círculo de Vida. And today we provide a variety of supports, psychosocial support services. That includes support groups, one-to-one support via home and hospital visits, which I'll talk about a little later. And we also provide in-hospital program at San Francisco General for newly diagnosed Latinas. So there's actually a peer support counselor there that goes in with the doctors when she receives some news of her diagnosis. So we're there from the very beginning to provide that support. And then we also collaborate with other organizations. We provide a Liquid Feel Better program in Spanish in partnership with the American Cancer Society. We work with the Breast Cancer Emergency Fund and other organizations here in the city to make sure that our clients receive all the resources that they need to get through this very difficult experience. I met Ana 18 years ago when I began work at the cancer support community. And when I took over the Spanish language support group, initially we worked together to provide breast cancer awareness and early detection seminars to underserved Latinas. And then we recruited and trained over 110 volunteers to distribute Spanish language early detection materials to the Latino population in the Mission District. In 2001, Ana recruited me for a research fellowship at the University of California, San Francisco. And the aim of the fellowship program was to provide community-based cancer professionals with research training to conduct community-based research on cancer issues among Latinos. And it was during this time that we developed a research question to identify the obstacles to use of cancer support groups among Latinos with breast cancer. And I'll talk about that a little bit. But before then, I wanted to acknowledge some of our partners, the California Breast Cancer Research Program, that has really been a real support to us in our work over the years. Redes en Acción, which is a program through Ana's organization at the university, the National Cancer Institute, and then all of our community partners and program staff that have helped us throughout the years. Before I get into our studies, I just wanted to talk a little bit of some of the things we know about Latinas and breast cancer. I know that there isn't a whole lot of studies done on the psychosocial needs of Latinas, but we do know that breast cancer is the most common cancer among Latinas and is the leading cause of cancer death. And over 96 Latinas survivors lived in the U.S. in 2006, and then we know that Latinos are a fast-growing ethnic group, and they'll be 30% of the U.S. population by 2050. We know that Latinas are at higher risk for psychosocial distress because they're diagnosed with more advanced and aggressive disease, They tend to have other health issues besides the diagnosis of breast cancer. Many lack the knowledge about the illness and then self-care after and what to do after the diagnosis is given. We tend to work at Círculo de Vida with lower income poor Latinas who have a lot of financial hardships. The majority do not have health insurance or are underinsured, and the majority are not familiar with the healthcare system. And as we know, there are not a whole lot of programs out there that are culturally and linguistically available for Latinas. There are some articles that have come out that indicate that Latina breast cancer survivors have great concerns about recurrence, about pain related to a diagnosis of breast cancer, about fear of death. They hear cancer and they immediately think that they will die. They are more concerned about complications that may come up during chemotherapy or radiation treatment. They're more concerned about body image, weight gain, sexual functioning, and then rejection by the partner. As I mentioned, Latinas tend to be have no health insurance or no self-employed health insurance. 13% of the population. Latinos make up 13% of the population, but yet 30% are uninsured. And people who are uninsured, Latinos who are uninsured, don't have a regular doctor, so they don't go for regular checkups. Therefore, they tend to be diagnosed at a later stage with less treatable cancers. And then 38% of Latinas age 40 and over don't have mammograms. So as I mentioned, the fellowship gave us an opportunity to think about a research question, and I was pretty interested in why some Latinas take to cancer support programs and others do not. So we got a funding for a pilot study from the National Cancer Institute Special Populations Network Program. And the aim of the study was to identify predictors of cancer support group utilization among Latina breast cancer survivors through a cross-sectional telephone survey. We recruited Latinas from the Greater Bay Area Cancer Registry from 4 counties in the San Francisco Bay Area. And what we wanted to do was explore the reasons why Latinas did not use cancer support group. We had a pool of 1,133 women. 29% we were unable to contact. 22% did not meet the criteria for the study. 14% declined. 6% were too ill because of cancer treatment or deceased, and we ended up having a 330 women, and then 67% response rate among those that we contacted. About half of the Latinas that we talked to spoke very little English or not at all. About 2/3 never saw a doctor who was bilingual, and the majority used a professional, or the doctors used a professional interpreter to talk with them. Over half, and this is one of my big problems with the medical field, is that they use a family member or a friend as an interpreter, which is, for me, quite unethical. So what we found was that Latinas will use support services when they are culturally appropriate. They have to be language appropriate and in Spanish language formats. We also found an interesting factor that women were more likely to attend if a family member or their provider encouraged them to attend a support group. We found that spirituality, religion was a very big factor, and it was a source of support for many of our clients. And then cancer self-efficacy is key to better perceived health. So we found among non-users that the 2 main reasons were not needing a support group and lack of information about groups in their communities. So now that we recognize some of the barriers, we wanted to look at to see what an intervention would look like. And so that brought us to our second study, and our goal was to collect formative data to evaluate Círculo de Vida, because we had never been evaluated, and we know that our programs work, but as you know, everybody wants data to back that up. And then we wanted to obtain input on the design of a peer support counselor intervention that could be tested in a randomized controlled trial in a subsequent study. We looked to our peer support model that we developed by Círculo de Vida, Las Angelitas, the angels, or the angels in Spanish. And Las Angelitas are a group of former group members that we train to provide one-to-one support to via home and hospital visits to Latinas who are too ill to attend a support group because of cancer treatment, to Latinas who elect not to join the support groups, and to those in the terminal phase of their illness. And they provide not only emotional support for the patient and their families, but they also ensure that they understand the surgery and treatment recommendations. Because I feel the more people know, the better they handle their cancer journey. And then the Angelitas also link those women, our clients, to resources in the community that are not provided by Círculo de Vida. And then they also identify barriers that may prevent them from receiving quality cancer treatment. We obtain our data from semi-structured interviews with Latina cancer survivors in a wide region of the San Francisco Bay Area, with community advocates, and also with Latinas who were referred to Círculo de Vida for support services. And we found that many needed information on cancer, believe it or not, that even though I'm a survivor, so I know what it is to receive that news that you have breast cancer. But imagine if you didn't speak the language and someone was translating for you, a family member that sometimes hold back information in order to protect the patient. So their information, what they had was very limited. So we felt that a part of the intervention would be providing them with simple to read information about what was going on with them. We also felt that advocacy was an important part of an intervention, so that the peer support counselor would help them navigate the medical system and also obtain resources for them that would help them throughout the process. We also felt that a need was increased awareness of support services. So we felt that the peer support counselor needed to initiate contact with the patient, and that's what we do at Círculo de Vida. We don't wait for the patient to call us, we call them. So everyone who refers to us knows that they should ask the patient for permission to give us their name and number so that we can make the initial call. Those first couple of weeks after you're diagnosed, you are very busy. I mean, you're going from appointment to appointment to appointment, and the last thing you want to do is call someone about a support group. So we initiate that contact to make sure that they are provided services. And then we also talk to family and providers to encourage their patients to come to the support group. And also one of the things we found was a big fear of dying, and so the peer support counselor would need to alleviate some of those fears by evoking hope and by encouraging spirituality and faith and those kinds of things. Emotional support is certainly part of the intervention, and with compassion and with care. Helping Latinas express their feelings and their needs. So the peer support counselor would need to express those behaviors or model those behaviors for the client so that they can reinforce practice. And then help the client build self-efficacy through stress management and self-care skills so that they can lessen that sense of powerlessness. And then help them with interpreting the materials that are given to them, and then translating materials that don't come in Spanish, and then sharing some of their own background about their own survivorship. We saw that the family plays a central role in Latino culture, and the importance to provide them support and to help them in how to support their family member who's diagnosed. And then respecting people's spiritual beliefs or religious beliefs was an important part of the intervention that we felt needed to be there. And then building confianza, that's trust, through personalismo. And personalismo is a Latino cultural value that's very important. And it's just the importance of warm interpersonal relationships rather than cold clinical type approaches that many of our medical providers do. And then we found that one of the needs were transportation needs. So we developed an intervention that would have the peer support counselor go actually to the house, to one-on-one and travel to the house rather than having the client travel to them or to a center, and then also provide phone support as well. So that brings us up to our present study, Nuevo Amanecer, New Dawn, and it's a 3-year study funded by the California Breast Cancer Research Project. And we wanted to adapt and test an evidence-based psychosocial intervention for newly diagnosed Latinas, and to do that we wanted to integrate something that was already done and then input that with information from Latina survivors and community advocates and community-based organizations. Some of our partners are Latina Contra Cancer in San Jose, Women's Cancer Resource in Oakland, San Mateo Medical Center in San Mateo, of course. And then we also have working with some people in Contra Costa as well. So our initial aim was to recruit 170 Latinos diagnosed with breast cancer within a year of their diagnosis from 5 San Francisco Bay Area counties, and we would randomize those women to an intervention group into a waitlist group. And then our conceptual framework that we were working from is that we believe that coping skills training by a peer support counselor, someone who's been through the experience, will increase coping, self-efficacy, and support, which will lead to increased quality of health and decrease in distress, anxiety, and depression. We looked at an evidence-based intervention already developed by Christy Graves, which was based on social cognitive theory components. And her intervention was done with white women in a group setting. And it included relaxation skills training, cognitive restructuring, which just means changing negative thoughts into positive thoughts, improving communication with providers and family members, modeling of behaviors by the peer support counselors, and then helping them with goal setting and self-monitoring in order to build self-efficacy. The cultural factors that we included into our intervention was personalismo, warm interpersonal relationships, and then all of our women who are providing the intervention are bilingual, bicultural, language appropriate, that would include emotional and information support for both the patient and the family, that would help patients navigate through their cancer journey, and that would refer clients to different services within the community. We formed a team from diverse backgrounds. We together identified key cultural themes, values, needs, implementation for delivery and intervention. And then we looked at Christy Graves' intervention and identified key components of that to be adapted into our intervention. So we integrated both those, the cultural aspects taken from the Angelitas model and then Christy Graves' evidence-based stress management program. Integrated both of those, had it translated into Spanish, had it reviewed by a diverse group of experts. We pre-tested it and then we tweaked it depending on the results of that pre-test and in order to finalize one. So I'm going to jump. So we came to develop an 8-week manual intervention delivered by trained Latina breast cancer survivors, and that would focus on stress management skills, training, and emotional support. We developed MOUs with the community-based organizations within the 5-county area in San Francisco, and they would help us recruit and deliver the program. And then we provided training to both the compañeras, who we call the peer support counselors, and then we're also providing supervision throughout this whole time until the end of the study. We presently have recruited 30 women. We were 130. Sorry, 30. We revised our target to 140, and we expect to have that by September of 2013.
And that's because we have excellent nutrition, because we're finding that the people are really depressed that we're reaching, so they stay in the program and they stay in the control group, the wait list, even though they have to wait 6 months. So we've only lost one person so far in the 2 years we've been recruiting.
So our partnership works because we're taking two aspects: Círculo de Vida, which has a long history of providing culturally competent services. We have already an established peer support program, Las Angelitas. We have credibility in the community. We provide clinical supervision, and we have that experience, and also we work with Latina breast cancer survivors. And together with UCSF, Ana, who is expert in grant writing and health disparities research, and she has access to theory-based cognitive behavioral stress management intervention and scientific literature in Latina cancer researchers. So that's it. I'm gonna turn it over to Ana.
Are there any questions about that first part? We kind of breezed through a lot. I'm just going to emphasize a few key points before I jump into my piece. But
the idea Latina is super broad.
Right.
So did you find that you ended up sort of selecting for people who fit that traditional cultural framework and didn't speak English?
We were
find that you had a diverse
we
group
were
of
targeting
Latinas?
Spanish speaking first of all.
Okay.
Yeah, so we were looking at more traditional, because those were the people that weren't able to get access to services. At least that's why it followed a national progression for us. With Carmen at UCSF doing this research fellowship, it gave her an opportunity to learn about research, and we started. The question came from her, from the community. Why do some Latinas use services and others don't? And so then we started with the population-based approach through the registry, where we were doing a quick 30 minutes. It's hard to keep people on the phone that long nowadays, but then people were doing it, and just to get the lay of the land. And that's what we found, that unless women weren't aware of the services, and those were the ones that weren't using them, and two, that transportation was an issue, and that we knew if they were encouraged by family members and their oncologists that they would use the services if they knew they were culturally appropriate and in Spanish.
So when you talk about involving family members and encouraging the patient, how did that actually work?
What we do in our current study, where we're implementing the intervention, is that the compañera goes to the house. So she we try not to have family members present, because we want to focus on the individual and in terms of the skills building. But she definitely has interaction with the family in terms of saying, this is what treatment's about. This is what you can expect. These are people's, normal reactions to diagnosis and treatment, and this is what you can do as a family member to help. On the flip side, what we found lacking in Christy Graves' intervention, and I'm not criticizing her at all, it was a totally different population, is that she had nothing on family. And so because it was such a big issue for us, and knowing the culture and what came out of all the qualitative work we did, we built a chapter, a module in the intervention that focuses exclusively on how to communicate with your family, how to talk to kids, how to talk to adolescents, how to talk to your partners about it. So that, broken out by kind of language, by age, because relationships are very different. And a lot of that also came from Carmen's experience, because her community organization provides support groups and therapy for kids whose mothers are diagnosed. So, we blended that into the intervention. And I think the other important point about how we got to the intervention is that you know, we really, once we had an idea of why women didn't use these services, and we really went back to the community and said, okay, now we want to create an intervention. What should that look like? And so we interviewed advocates that were working with Latinos who were either getting diagnosed or their family members. We had focus groups with Latina breast cancer survivors, and we also did individual semi-structured interviews with survivors, with Latina survivors. And then in addition to that, we did the survey, as Carmen mentioned, of anyone who had been referred to her organization in the past 5 years, I think we went back 5 years, who had, regardless of whether they decided to elect to use the services or not. And that's where we used all that information, because I really love using mixed methods, the qualitative and the quantitative, because they give you more of a full picture. And then that's where we developed that framework that she went through, where we identified kind of the needs and then looked at what were the implications for the intervention in terms of how we would design it. And then we took it back to the advisory board, and you know, it was a very iterative process that took a long time. It took a good year to get that finally in a manualized 8-week intervention. So it's a long process, but it's a lot of fun, and you learn so much if you can do that, if you can go out to your communities, as well as the professionals that are delivering services in the community settings to the population, to be able to actually develop the interventions. And then you learn a lot, because we wanted to, one of the things that I think we do that people are starting to do and you read more about, but the methodology for doing it isn't really published in the scientific literature, is how do you take evidence-based interventions, you know, and in the public health arena, CDC, the people that are funding the state, at the state as well, the programs are requiring that you, as a public health provider, integrate evidence-based interventions into your programs. So how do you do that and also match it up with the best practices that are being, you know, because the communities know what they're doing. They develop programs that are responsive to the communities, that are taking into account the context, you know, the educational levels, the geography, do people have to travel huge distances, you know, what are the resource limitations that you have within that context, and that's what the communities do. So if you can, the beauty is if you can blend, you know, what we know in these structured kind of efficacy trials about what works and what doesn't, you take the nuts and bolts of that, the active ingredients, so to speak, and then you blend that with what we know is working in the community. You can come up with a kind of a hybrid, right, that really works, hopefully, and that's what we're doing, is we're testing our hybrid. And so we're supposed to touch in this session about collaborative data analysis and dissemination, and also the data collection. So I'm going to give you examples. You know, we're using the Nuevo Amanecer as a case study, but there are many different ways to do it, and we're learning new ways as we go. We're planning on trying new ways as we get the results of our current study, which we should have in the next 6 months or so. But feel free to pause at any point. We're going to give you an exercise, and I want to leave some time for that, so that we can have a discussion about, because I really want to hear from your perspectives as well and your experience, you know, what's worked in terms of disseminating and analyzing data, presenting it, and you know, what kind of formats, what kind of audiences, what's the purpose of dissemination, all those things. Oh, this is an old slide. Sorry about that. But so first of all, in Nuevo Amanecer, one of the things we did is we collaboratively worked with Círculo de Vida, with the whole organization, and the angelitas that they have within the organization, with Dimas, who is Moncada, who's the clinical supervisor, and we identified constructs that we wanted to study in terms of what we thought would be responsive and to the intervention and would move with it. And so we did that also in the first study, where we did the population-based survey, where the community partners worked with me and my staff at University of California, San Francisco, to look at, okay, what are the predictors we think of the services and why people do and don't use them, and what are the mediators of the outcomes, which is use of the services in the first study. And then we developed that survey and pre-tested it. And then, so the things we were looking at within that population-based survey that we also have now incorporated in terms of the surveys we're using for the intervention study is we're looking at quality of life. So we use a standardized functional assessment of cancer therapy, the FACT-B for breast cancer, developed by David Sella and colleagues, so that we can compare to other studies, our population. We also we developed our own scales of barriers and benefits, perceived barriers and benefits of using support services, since there weren't any in the literature culture at that point. And then we looked at patient empowerment, because that was a big issue that came out of our advocacy work. You know, that the advocates are saying one of the issues is that women aren't assertive, you know, especially really traditional women that don't speak the language, so they won't question their providers, they won't, you know, they won't ask for help when they need it, or their family members and the people who are in their local, you know, environment that might be able to provide them the support. And then the issue of worry and cancer and impending death, as Carmen mentioned, it was a huge one, and so we tried to tap into all that. And the issue of language, obviously, whether you have interpreter services. And so for Nuevo Amanecer, our intervention study, what we did is we went to the CBOs and we said, okay, you're doing this kind of work already in the communities, you know, can we just train your people to do the recruitment, which means they have to take some human subjects training, they have to learn about techniques about how to be an effective interviewer, and they also, you know, of course they had to be bilingual, and they also had to know about informed consent procedures and how to take a good informed consent. And then, so we did all that. The CD training is an online training that you can take, takes about 3 hours, so we actually had to get all of our community partners to commit to doing that. But we, pardon? Go ahead.
It's a pain in the butt.
It's a pain in the butt, but it's a requirement if you're doing any type of academic institution and community collaboration, because the IRBs, institutional review boards, will ask you as an academic investigator, I want to see proof that your community partners, your non-affiliated sites, have taken human subjects training, and I want to see the certificate. And I want a letter that they'll accept your, you know, our institutional IRB approval if they don't have an IRB themselves. So you have to be really familiar with all those procedures, which adds kind of another layer of bureaucracy and complexity to working in these partnerships, but it's very doable, very doable. And so we trained their recruiters. We did in addition to the online training on human subjects, we did a 4-hour training in the office where we brought the recruiters in and went over how to do the interviews and, you know, what the measures were and why we were asking about those particular measures and how to do informed consent. And you know, if you're doing the informed consent, our IRB you know, makes us read it aloud in case there are any literacy issues. You know, we have to verify that they've understood the content, and then get their signature as well as serve it as witnesses, and then give them a contact in case they have any questions. But what we found, and probably most of you have too, if you're doing research in the Latino community, is that it really takes that in-person contact. Because a lot of the communities that we deal with that are very traditional, that are, you know, new immigrants especially, they don't have the familiarity with the research process and what it takes. And there are many different kinds of research. So I think if I'm a recruiter, I really go to great lengths to explain to them, this is what the study entails, this is why it's important for you to participate, and this is why we really value your participation, because we can't do, you know, we can't advance the science or learn more about these issues unless you're willing to share your experiences, you know, and be honest about it. So those recruiters are compensated as part of our study funding. We got 2 separate awards. The California Breast Cancer Research Program Community Research Collaboration, CRC awards are a great mechanism. I hope at some point they develop them in other states as well, but it's a unique California-specific funding mechanism that gives half of the award to the community partner and half to the academic institution, which really, really fosters, you know, equal footing, equal collaboration, and equal power in the relationship. And all those are really critical. And I want to add, and also excellent communication, because problems will always surface, especially when you're in the field and you're implementing. And so if you've established that relationship and that good communication, when you get to the point where you're implementing, you know, those issues come up and you talk it out, and you see each other's perspectives, and you make a joint decision about how to resolve those issues. And all that takes a lot of infrastructure building up ahead of time and relationship building. So these recruiters participate in the monthly, oh, I'm sorry.
Just really fast, what was it called, the agency that provides this funding?
The funding California Breast Cancer Research Program, and I'm going to have Zenaida Fernandez in the back hold up her hand, because she's our program officer, and she could certainly tell you more about the project, and you can look online too at the CRP website.
Thank you.
Sure. please ask any questions. And so, one of the things that I love about the way we set up the study is we have monthly conference calls because we're in a 5-county area, and I mean, we literally sometimes travel, I would say at least 2 to 3 hours to get to some of the places where we're actually intervening. And so because of that, these conference calls are key to really keeping in touch with our field staff, these recruiters that are in the CBOs. And they're supervised by our project director, which is part of my staff. And she's bilingual, bicultural, and has done this kind of work for a long time. And so we also hired the interventionists, and we call them compañeras, which means companions, because you know, we felt it was really a journey once you're a cancer survivor, and that this person represented someone who was walking that journey with the women that were being newly diagnosed, and someone who had walked that journey themselves. And so it had a lot of, I think, you know, a lot of connection with the women when we were training them, the interventionists. And so we jointly developed the program, the training program. It was a 3-day, 24-hour training program. And we went over the intervention, about research, about Latinos and cancer, about how to culturally adapt interventions, what some of the special considerations are when you do that. You know, we went over the framework we had used, because we not only had to adapt it culturally and linguistically, we also had to adapt it because the evidence-based intervention was delivered by a clinical psychologist in a cancer center. So we had to adapt it as well for delivery by lay people, lay leaders in the community, as well as for delivery out in community settings where we had less control than you would in a cancer center. And so a lot of that went into the training of the compañeras, and they also participate on the monthly calls. And they're supervised by Círculo de Vida, the clinical supervisor, you know, because Carmen's a clinical psychologist and her staff all are masters level social workers, other than the peer Angelitas that she uses. And so the CBOs receive a service fee for being a partner and giving us access to their population and their personnel. And the compañeras are compensated as well for delivering the intervention. And this slide doesn't do this justice, but one of the really fascinating things I'm learning now is we're going through all the process data. And luckily, we set it up very well initially, where we created tracking sheets and trained the compañeras. And also, I think they just really want the program to work, and they really want to learn how to do it better. So they write very extensive notes on the tracking sheets. And we also have a sheet they fill out at every session that, you know, that says how long they traveled, you know, how long the session was, whether the participant was able to answer a couple of refresher questions from the prior session. So we have a lot of that, and there's a number of other examples of process evaluation data that right now I'm having interns enter, and we'll be able to analyze as well, because I think it's just as important as reporting your outcomes, and whether the outcomes of interest moved or not is the process evaluation. Because you learn a lot, because I think one of the things we're learning is we overshot, even though we tailored it for like 5th, 6th grade reading level, that a lot of the women are illiterate. You know, they don't read and write, they don't know. So doing homework, even though we created this, we adapted Christy Graves some of the homework exercises to be very simple, and some of the forms to be very simple, where they were monitoring their levels of fatigue, for example, or distress, you know, on a 0 to 10 visual kind of scale. All those things proved hard in some cases, and so it took a lot of extra time and work on the part of the compañeras to be able to actually do it with them. So a lot of times at homework they couldn't do independently. They had to actually do it during the sessions, which means the sessions then became longer. So anyway, the compañeras are really helping us. They play a key role in the process evaluation. We have a lot of written notes, and that's all qualitative data that we're inputting into a database that we'll be able to analyze. And so they're really tracking the strengths and weaknesses of the program as we're delivering it. And they also keep extensive notes on issues that arise. You know, what were the challenging issues in terms of financial hardship, in terms of talking to their families, and so we have all that in the database. And the other thing we've done is they let us audio tape the sessions. You know, we told them we wanted to, you know, one of the things we use our yardstick is fidelity, right? How well did they adhere to the manual as we intended it to be delivered, the intervention. And so they they let Carmen go, and Carmen takes a little rating sheet and she rates them while they're delivering the intervention and using the, you know, how well they stuck to the intervention as intended. And then she also audio taped them, and now we're having independent observers do the same kind of rating, and then we'll look at agreement across all three, her and the two independent observers. So those are just things in terms of data collection, process evaluation data that is ongoing and that will be really useful, and we'll put out in the literature so people that want to develop these lay delivered, you know, peer delivered interventions can learn from all those experiences.
For the peer, or for the lay leaders, were they also shared the same demographics, like as far as education goes?
Yeah,
or were they
you know,
a bit high?
What we did is we let the CBOs identify the people, and what ended up happening, which we weren't aware of when we trained them, was that you know, what we did a little demographic sheet, and after we trained them, we actually looked at it, and they all happened to have a college level education, but in their home countries, because none of them were U.S. born. So we ended up, you know, they just became, but that's a natural kind of process that happens in the communities, that they're the ones that actually end up taking these leadership roles in their communities in terms of being health advocates within the local settings, right? So that's a good question, because we thought we would get more of a, you know, diversity in terms of their educational backgrounds, but we were surprised to learn that they all had almost college or college level in their home countries. But that, you know, they were so committed. I mean, they are committed. It's amazing. And they grasped everything and the importance. They wanted to know the theory, and I think that's what drives a lot of this heavy note taking that they're doing too, is they really get into kind of the science behind it and want to learn more, learn how to do it better. And so I really want to stress that on these monthly conference calls, that's part of kind of our data collection process. We learn about, that's where we've learned a lot about what's working and what isn't in the field. So the literacy issues, their inability to do the homework sometimes for some of the women, and which creates you know, more of a time burden on the compañeras to actually do it with them. And then they've in turn shared a lot of community resources with each other, and so we created more comprehensive lists of community resources. So they really serve as resources for each other and create a network there. And we've had we had one refresher training, and it was really, you know, they bond too as a group. They get to know each other, and so we want to at some point get additional funding to look at kind of the effect on them, on how it's changed them, and how they've created kind of this network amongst themselves. And so we're trying to get funding, and we had a postdoctoral fellow apply for a diversity supplement on our Redes en Acción grant, which is the main network grant, to try to do some of the debriefing with people who've gone through the program, as well as the compañeras that are in the program. And so just to go back to study one, which was a telephone survey, the cross-sectional survey, as I mentioned, Círculo de Vida actually generated the research question. We kind of split it up since we had the data analysis skills, where we, UCSF, analyzed the data, and then we would have joint team meetings after. So it's a structure we use to actually review the results, where we go over the printouts and make decisions about what would go in a manuscript, you know, what we thought the important messages were to convey back out to scientific audiences as well as lay audiences. And so we co-authored a manuscript on that. And in the pilot, where we did all the mixed methods work, the formative evaluation to develop intervention, we did the same thing. I think we at UCSF had the software to do the qualitative data analysis. We ran the data analysis and had independent observers doing ratings of some of the quantitative stuff, as well as looking at the themes. And then Carmen and her clinical supervisor would look at some of the actual raw data, which was the transcripts, and then we'd sit down and identify and say, you know, get corroboration. You know, are these the themes that appear to be salient in the data, and are these the issues, and is this the implication for developing an intervention? And so we really got a big bang for our buck out of that first formative evaluation, because not only did we get kind of all the qualitative interviews and input from the community to inform the intervention, We also simultaneously did a program evaluation because we did that. Remember I told you that we called anybody who had been referred to Círculo de Vida, whether or not they had used the services. And so for the subset that had used the services, we went through and did a structured survey looking at having them evaluate the different types of services they offer and what they thought, and then some open-ended items asking them, what they would change, what the benefits were, what the barriers were. And then that allowed Carmen then to use that in terms of, when she seeks funding, now she has like a rigorous evaluation of her program that shows that people rate it very highly. And so another thing I want to stress in terms of the data collection, data analysis, is that we, and also the intervention delivery, it crosses over, is we do a lot of mentoring. Carmen does it within her organization, and it's something, and I do it at the institutional level at UCSF as well, because it's something we really believe in. So we're getting a lot of Latina trainees to participate in the data collection and analysis. And it really gives them insight and the good balance and what they're really excited about. I have 2 interns that are actually from here, from the health education program, master's program right now, and they're the ones that are doing all the data input of the process evaluation. So they're seeing all the notes and they're seeing what the issues are, and they're seeing, it really acquaints them with what are the needs in the community, and also what are the compañeras doing. And then we'll eventually send them out to observe the session with the patients, the participants' permission. And I had an intern in the first study who was a medical student actually analyze the data and look at, the cancer coping and self-efficacy sense of and how that influenced well-being in the cancer survivors. So they really learn a lot, the trainees, and they value the exposure to the academics in terms of the data collection and evaluation, but they also value, the context, which is the community program that we're delivering and why it's so important and why and they get familiar with the big needs that are evident in this population. And so Carmen, I think, mentioned that in that first study when we did all the formative evaluation, one of the things when we got the pilot is she said, it's really funny because we know each other very well, as you can tell, but we had all these conversations, and she says, the one thing I want to do is I really want to, she wanted to have some kind of legacy, at least that's the way I interpreted it, and she can speak for herself, but so she wanted to develop a guide for the CBOs that would put, in this structured guide, what CBOs can do to develop these programs themselves, because again, it was kind of empowering the community to develop these programs, and here's a guidebook that will guide you through it. And so we did that, and it's up on our website. I don't know, it's probably up on your website too, and disseminated it as part of that formative evaluation phase. So we had, even though we didn't have very much money, we printed up, color copies in English and Spanish, and that was one of the dissemination tools we did, is we wanted people in the community to know what we had learned from all the formative work, as well as, the academics that would see the scientific publication. And so, and it really captured her model, Las Angelitas, at that point. And so, in addition to that, we've done 3 co-authored peer-reviewed journal articles, and again, we're trying to document in these publications the substantive findings, as well as some of the methods for doing this type of work. And those, we're about ready to submit our program description and almost done with the baseline. We're just waiting for the final people to be enrolled paper. So, we try to kind of stay on top of it and get them out as we go. But we did one from the Cancer Support Group study, what predicts it. We looked at coping resources. We have another one that we submitted, which was this one that the internship looked at cancer self-efficacy more closely and spirituality. And then the final one, the most recent one, which was how we developed the intervention. And I asked them to circulate that, so it's probably up on their website. I thought they would pass it out, but if you're interested in more of the framework that we use to culturally adapt what Carmen presented, it's in that last manuscript. And we've also, we team tag a lot. We do these presentations. We've done them at 12 national conferences, 9 regional or local conferences, and we've had some of the organizations are the American Psychosocial Oncology Society, the CBCRP Symposium, the American Association of Cancer Research, the Gerontological Society of America, and we do presentations to our CAB and to some of our clinical partners as well. And so, for the current study, our dissemination plan, which is, in development, we haven't really finalized any of this, is that, we've been doing presentations along the way, and we'll do it in terms of the program once we show that it's effective, hopefully. And then, as I mentioned, we have 2 peer-reviewed articles in the wings, and then, we also want to do some kind of executive summary or policy briefing about these issues, because I think we need to raise attention that the immigrant populations in all of our states are growing, and that these are people that are getting left behind in terms of these psychosocial support services, and they're also the ones that are going to probably suffer disproportionately high distress because they don't speak the language and aren't well informed about what to expect in terms of their treatment and how to ask for help and how to navigate the system, all those issues that Carmen talked about. One of the things that we're doing, and I'd be really open to your suggestions, especially those that are working day to day with community folks, is we want to do, we definitely want to get the results back to the people that are participating in the program. And, the easiest way to do it is and the cheapest way, because we are obviously on a limited budget, is to do it through a mailing. So we'll probably do something that's very either graphical, where it's more visual, and gives them the final results. And I think this is really, really key, because one of the things that I feel strongly in is that we really have to convey to participants that the value that they bring to the research. If they don't feel valued, they're not going to say yes at subsequent time. And so in this mailing, that's what we want to do. We want to really stress, we were able to learn this because of you, because people like you were, gave 8 weekly sessions of, participated in them, gave their input, filled out all the surveys that we did, and this is the outcome. This is what we've learned. And so, we probably will end up doing something with social media as well, like Facebook, put up a Facebook link to our study findings. And, we do plan, once we have the results and show that it's effective, hopefully, to put the program materials up so that anyone can use them in both Spanish and English, because we have it in both versions. And we have a manual for the participant, and we have a manual for the compañera who's delivering the interventions. So they're joint manuals. And we would definitely be open to providing technical assistance, because one of the problems is that we get these manualized interventions, and you can get them. I don't know if you know, there's a research-tested intervention site. It's called RTIPS, that CDC funds, and NCI, they do it jointly. It's just, if you Google RTIPS, it's a great resource, but they have all these evidence-based interventions, which means there's some research evidence that shows that they're effective. And you're supposed to have access to all the program materials and also all the caveats of, how it was implemented and why it was implemented in the way it was. But it's a good resource, but there's also a lot that they don't teach you or isn't available online, right? So that's why the technical assistance is so important.
Can you repeat that website?
Sure, it's just RTIP.
Oh.
Research Tested Intervention. I forgot what the P stands for, program maybe. But they have, I'd say, well over 125 interventions on there, covering, it's all behavioral stuff mostly, but covering different behaviors. But one of the things that, if you look at the scientific literature, what happens is when people go out to disseminate these programs and they do some research in terms of the dissemination of the evidence-based programs, is that unless you have ongoing technical assistance, you don't get the same results usually as was done in the original effectiveness trials. And so the technical assistance is really important, so we want to keep doing that as we disseminate the program later on. But just to give you a little sense of how people feel, these are some testimonials of people who've gone through the intervention, and they were willing, they gave us permission to use their picture as well as their quote here. Julia says, "I thought it would be more difficult, and I was very afraid of the treatments. The Nuevo Amanecer program explained what could happen to me. It taught me how to take care of myself when I was on radiation and chemotherapy. It helped me to overcome my fear." So again, that cultural theme of fear and not knowing what to expect, being less familiar with the types of treatments that they were going to undergo, comes out very strongly, and that's what we targeted with intervention. So it looked like she got what we hoped she would get out of it. And then Dora's story. It has given me great joy to know that there are people out there who work on programs like Nuevo, Amanecer, and that they take care of me. Again, this is a great testimonial for participation in research, and that's why we use this one a lot too, because unless people know the value of their participation, they're less likely to say yes. So I want to talk there. I handed out an exercise, and I would really like to spend like about 15 minutes, maybe 10 to 15 minutes, having each of you. It's that one pager. Think about why you came to this session in terms of what you're trying to do through your dissemination. And I'm focusing on dissemination and less so on the data collection and data analysis, because I think those grow organically out of your partnerships. One person's better at one thing and another person's better than another, and so you negotiate that. And as long as you're jointly reviewing the results and interpretation and writing those up and disseminating, those are the really important pieces. It's to make sure that that they're vetted by all important stakeholders and players. And so what we're I think least well versed in is the dissemination piece, and we're learning as we go. And so I really want to take the opportunity for the next 10 minutes or so for you to really think about your own projects and your own communities and what you might be interested in disseminating. And so I'm going to have you go through and just take 10 minutes. And the first question asks, what is the purpose of dissemination? So what is your purpose in getting whatever information you want out there? And then who are the intended audiences, specifically? And then what is it you want them to take away? What do you want them to learn about what you're disseminating? And then what's the best, because each audience is different, what's the best way to convey that information for each of your audiences? And then finally, what role will various partners play in the dissemination efforts? So I think we'll give you about 10 minutes to do that little exercise. And then what I'd like to do is review it, and Carmen and I can answer any questions you might have, and have a few of you kind of volunteer about your what you learned from doing that little exercise, and see how everybody feels about dissemination and what are some good strategies.